This is about evaluation and management of hyperlipidemia in children, which is both a controversial and complex issue, which we'll discuss in a moment, but an essential one in the evaluation of overweight and obese children, which of course is the focus of this course. The project is funded by a grant from the Sprague Memorial Institute and IDHFS. I don't have any financial disclosures of any kind to make at this time. The basic objectives are the following. First of all, to provide a rationale for screening for lipid disorders in children. And this is a really important starting point because it's often difficult to convince physicians and to convince, not to mention parents and others, of the value of screening for lipid disorders in children. List the upper limits of reference values for lipids in children of different ages, the current screening recommendations, and describe a rational approach to treatment of children with different degrees of lipid disturbance. So let's get started. So as far as the first question goes, why do we bother? Well, there are multiple different rationales. First of all, we know that lipid disturbances have become more common due to increases in rates of childhood overweight and obesity. So gradually we've seen an increase in the average value of LDL, for example, over the last 20 to 30 years, and it closely parallels the increasing prevalence of obesity. We also know that lipids and cholesterol in general are part of an integrated approach to screening, evaluation, management of cardiovascular risks in children. So the latest NHLBI guidelines, which came out about 1.5 years ago, describe an integrated approach. So you don't view obesity in isolation of hypertension, in isolation of lipid disorders. And of course, our course is structured that way. You have to address all of these problems simultaneously. And so lipids are part of that. And because they're part of the integrated approach, we do need to learn more about them. There's also evidence, so this is often a question that comes up, is what evidence do you have that screening and treating for lipid disorders in childhood has any impact whatsoever on cardiovascular disease in adulthood? And clearly that evidence is going to be extremely difficult to gather. However, we do have some indirect evidence that I think is valuable. So first of all, autopsy and vascular studies, as morbid as it sounds, that the young children who've been subjected to autopsy after accidents, for example, do often have evidence of early atherosclerosis, and vascular studies also confirm this. We know that children who have heterozygous familial hyperlipidemia, which is one of the more common genetic forms of hyperlipidemia, do tend to develop coronary artery disease or other manifestations of atherosclerosis in their 20s and 30s. So that's strong evidence of childhood lipid disorders being a precursor for adult disease. We also know that tracking of lipids into adulthood is very common. So even though in the adolescent period, a child's lipid profile is rather unstable, meaning it changes a lot, it can improve or get worse, we know that children who have high cholesterol in childhood tend to have high cholesterol in adulthood. And of course, we know that high cholesterol in adulthood is associated with cardiovascular disease. So essentially the message is that atherosclerosis begins in childhood. So within the first decade, we start to see the early lesions associated with atherosclerosis, foam cells, as well as fatty streaks. Subsequent to that, in the 20s and in the 20s and 30s, second and third decades, we start to see intermediate lesions and even atheromas. And then beginning in the fourth decade of life, we start to see evidence of fibrous plaques and, of course, complex lesions, which can lead to serious problems. So essentially, this is a longitudinal look at how atherosclerosis develops. Of course, if we only screen at this point, let's say in the 20s or 30s, we've actually missed out on preventing much of the disease process that takes place prior to that. So that having been said, there are many significant barriers to screening for lipid disturbances in children. And I've classified these in a couple of ways. First of all, we have significant physician and health system barriers. So the lack of knowledge of screening recommendations, and of course this is common for many different problems because it's not something people are yet very familiar with. The lack of belief in the value of screening is a significant one. So, you know, is my child, my patient, going to really benefit from screening for lipid disorders in childhood? And in relation to other priorities, other conditions the child might have, or is this really valuable? So you can imagine that we know that autism screening is now recommended and valuable and is generally being carried out and does take some time. That having been said, should I invest some time and effort in explaining the value of lipid screening to my parents and children, and also should I carry it out? The lack of identification of candidates for screening is complex, and we'll talk about that in a second. One of the important barriers to screening itself is, what do I do once I've screened? So lack of knowledge of follow-up and treatment guidelines is an important barrier, and the lack of laboratory resources as well, which we'll talk about. So patient-related barriers include, number one, is convenience. So until fairly recently, children had to be fasting and often had to go to a location outside the office for screening. This is inconvenient. Discomfort, of course, is very difficult. You can imagine to obtain any sort of blood sample on a young child in particular. It also ties up nursing staff for some time during a busy clinic day. The lack of belief and value of screening, of course, is not only shared by physicians but also by parents, and failure to understand the results. And what do I do? So my child has high cholesterol, and you're not putting them on any medication, so what does this mean for me and my child? How do I proceed from here? So all significant barriers, and I'm sure that you've encountered many of these yourself. So in terms of principal questions to meet the objectives that I outlined at the start, what are the reference values for key lipid components? And I think this is important to remember, because if you start screening large numbers of children, certain threshold values will become very, very obvious and very important to remember, and you can essentially not worry about the rest of the children. So in terms of total cholesterol, an acceptable level is less than 170, and high cholesterol is greater than 200, as it is in adults. An acceptable level of LDL is less than 110. 130 or higher is very high. Non-HDLC, and we'll talk about this in a second. I don't want to address this just now. And then the triglyceride threshold values are 75 is acceptable, 100 or greater is high, and if the child is 10 to 19, children that age tend to have higher average triglyceride levels, so the thresholds are 90 and 130. So essentially, if you remember about 6 numbers, the total cholesterol acceptable in high levels, LDL cholesterol acceptable in high levels, and the 2 levels of triglycerides, you've made some significant progress. In terms of HDLC, you want your HDL to be 45 or greater, and less than 40 is considered to be low. So another question that comes up, it's very important, is what are secondary and familial hyperlipidemias? I don't want to focus too much on these because they're still relatively rare. And in terms of screening and management, if there is a secondary hyperlipidemia, that's usually managed in a specialist setting. So in terms of secondary causes, certain drugs are responsible for significant lipid disturbances. The retinoids for acne, for example, are associated with elevations of all lipid components. Oral contraceptives to a lesser degree. Antiretrovirals, so if you have children who have HIV and are on antiretrovirals, these can cause significant lipid disturbances. Hypothyroidism is an important secondary cause. So if you identified hypothyroidism in a child and an accompanying lipid disturbance, it's incredible to see that even short-term treatment of the thyroid disorders, we're talking about just a few months, improves the lipid profile significantly. And chronic renal disease is associated with elevated lipids as well. In terms of familial disorders, this is a long list here. Not all that important, except to know that children who have these familial primary lipid disorders have very, very significant disturbances in their lipid profile. So familial hypercholesterolemia of the homozygous type has high levels of LDL, typically well over 200. Among these, the most common is the familial combined hyperlipidemia. The different subforms are not important. They just describe different levels of lipid disturbances. Polygenic hypercholesterolemia, of course, just refers to what we normally see. And the remaining things, the elevated triglycerides and some of the other types of hyperlipidemia, is less important to remember. So the other essential question we need to address is what are the recommendations for screening. Now these have changed recently, and I'm going according to the NHLBI integrated guidelines for cardiovascular risk reduction in children. So between birth and age 2, no screening is indicated. Between ages 2 and 8, you would only perform risk factor-based screening. So these are children who have a very strong family history of heart disease, less than age 55 in males or 65 in females. Children who have a parent with a known dyslipidemia or very, very elevated cholesterol. And this, of course, you're not going to find in every case. I mean, many parents don't know what their cholesterol levels are. If the child has chronic illness, including diabetes, high blood pressure, obesity, or smoking. Now, the obesity is one of those questionable ones. So should we be screening in all obese children in that age range? Probably so, because that's going to be a significant risk. On the other hand, some people would say it's not necessary at that age. You can wait till a little bit later. And if the child has serious illnesses, such as HIV, nephrotic syndrome, Kawasaki's disease, or chronic kidney disease. Now, the controversial part of the NHLBI integrated guidelines are the recommendations for universal screening, which should take place between ages 9 and 11. So this does not necessarily have to be a fasting specimen. So the requirement to obtain a fasting specimen was a significant barrier to screening prior to the release of these guidelines. So you can do a non-fasting lipid profile and calculate a value known as the non-HDL-C. Let me see if we can line this a little bit. So the non-HDL-C is calculated as the total cholesterol minus the HDL-C. So it includes the LDL, obviously, and other lipid components. The problem, the reason that we can't obtain an LDL value directly is because the LDL value is calculated based upon the triglyceride level, and therefore it changes in the non-fasting state. So if this particular non-HDL-C value is greater than or equal to 145 and the HDL is 40 or less, then it's time to do a lipid profile. Now, a fasting lipid profile, which you would get on 2 separate occasions. Alternatively, you can go, of course, directly to the fasting lipid profile. If the LDL is 130 or greater and HDL is less than 40, and the triglycerides are 100, then you repeat the fasting lipid profile one more time. For children greater than 10, the threshold for triglycerides is 130 rather than 100. So essentially, the protocol, when you think about it, is if you have a child in this age range, what's recommended is obtaining either a non-fasting or a fasting lipid profile, looking at the components, looking at the results, and if they are consistent with what's here, then you would obtain a second value to confirm the lipid disturbance. So what are the NHLBI recommendations for screening in adolescence and in young adulthood? Well, no routine screening is recommended between the ages of 12 and 16. This is because you do, perhaps due to hormonal changes, see some significant fluctuations in LDL-C values. LDL is still the target of therapy for children and for adults. And if there are new risks that develop, so let's say a child develops chronic kidney disease or they've gained an enormous amount of weight and become obese, then you can consider screening. But no routine screening is recommended at that age group. There's a very low predictive value for adult LDL-C values based upon the LDL-C values obtained in adolescence. Between ages 17 and 21, universal screening is recommended at one time. Between ages 17 and 19, it's the same as the screening recommendations for ages 10 and 11 with respect to the threshold triglyceride values, for example, and the need to repeat fasting lipid profile. And once you reach age 20, you're just following the adult recommendations, which we won't get into. So let's consider some of these recommendations in action and also consider the issue of treatment. So this is case study number 1. Greg is a 9-year-old boy with a history of well-controlled asthma and a BMI percentile of 98, so he's quite a heavy child. Father's just 42 and has suffered an MI last year. He's a former smoker, this is the father, and is extremely obese. The average of 2 fasting lipid profiles, so let's not worry about having to repeat it, I'll just provide you with the average, revealed the following: a total cholesterol of 210, LDL-C of 142, triglycerides of 180, and an HDL-C, which is low at 32. So the question is, what actions are appropriate at this point? So this is a child who has undergone the universal screening. The recommendation has been followed, and we have a lipid profile that is characterized by elevated LDL, elevated total cholesterol, elevated triglycerides, and also a low HDL. So complete lipid disturbance. So what do we do? Well, what's recommended, of course, as you can imagine, are lifestyle changes. These are the child, the cardiovascular reduction guidelines, recommendations for lifestyle changes, the child 1 and child 2. What they recommend is moving from a child 1 diet and activity recommendation to a child 2 recommendation, which is much more strict. Really nothing earth-shattering here, and to be honest, in my opinion, not terribly useful at all. A lot of these are things that all children should be carrying out. For example, limiting and avoiding sweet beverages, encouraging water, the fat content of foods, which of course is what's recommended for everyone, the cholesterol value being less than 300. Supportive actions to teach portion sizes, encourage dietary fiber, the DASH eating plan, etc. So many recommendations that we've seen for a long time. The problem is, how do you implement them, and will you have any success? If the child is, whoops, I'm sorry, let me go back for a second. So these are recommendations for children ages 2 to 10. If the LDL-C is significantly elevated, you do consider other additional recommendations according to the fat and cholesterol content of foods, plant steroid esters as a replacement for fat sources. They're referring, of course, to some margarines, which are a healthier alternative, etc. So again, difficult to implement recommendations. I think if, in the case of Greg, who's 9 years old, who is obese and has that widespread lipid disturbance, he probably needs much more practical recommendations. And these are things, of course, we've emphasized throughout this MOC, eliminating sweet drinks, limiting his screen time, incorporating physical activity, getting rid of fast food and energy-dense snacks, and to continue this process. And check his lipid profile roughly every 6 months to see how we are doing. So the lessons here are: give him some practical recommendations. There's no rush. There's no urgency in terms of medication treatment, for example. So let him pursue lifestyle changes, perhaps one goal at a time, until he's able to make significant progress. Now, that's another case study, which is quite different. So this is a girl who was part of a swim team, and as part of the swim team underwent a routine physical exam, which unfortunately included lipid screening. Unfortunately or fortunately, depends on how you look at it. Because she's 16, she really isn't a candidate for screening according to the guidelines. Nevertheless, we do have results to consider. So she's a 16-year-old girl who recently underwent a health screening, including a fasting lipid profile along with other members of her swim team. She has no family history of heart disease. She has no significant medical history whatsoever. She's 5'9" and weighs 175 pounds. BMI is 25.8. BMI percentile is 89. Waist circumference is 28. So this is a swimmer. She's tall. Her weight, of course, is high because of probably her elevated muscle mass. She also has a slim waist as well. So somebody who is fit, though certainly heavier than many of her peers. She's already meeting recommendations for the child 1 diet, so she's a healthy kid. We get that should be two fasting lipid profiles, which reveal the following. The total cholesterol is 260, LDL-C quite high at 194, HDL-C is decent at 50, and triglycerides are low. So what should we do at this point? Well, the essential answer is the best course of action is to continue lifestyle changes and to begin pharmacotherapy. So she has quite a significant disturbance in LDL. And in terms of pharmacotherapy, there are a number of alternatives. Of course, no medication has been shown that upon treatment in childhood prevents cardiovascular disease much later in life. That's just not, we don't have that data yet, may not for some time. However, we do have strong evidence of the safety and effectiveness of a wide number of lipid-lowering drugs in terms of improving the lipid profile. So, and there is some evidence of intermediate outcomes as well. So children, for example, with genetic or familial forms of hyperlipidemia who are treated with lipid-lowering drugs tend to have improvements, for example, in carotid intimal artery parameters, which is a surrogate marker for atherosclerosis later on in life. So there is some indirect evidence. And so in terms of the medications, what I would say is that at this point, this is probably treatment that should be carried out in conjunction with a specialist or can be taken care of by a specialist with some monitoring by the primary care physician. But a number of medications have been used successfully. What a lot of people do is to become familiar with only one or two of them. And then what I've used is Lipitor and also simvastatin as well. Simvastatin is available. It's quite inexpensive. You'll see that the improvements with Lipitor over 26 weeks are quite significant. 30% drop in total cholesterol, 40% in LDL, improvement in HDL-C, and a drop in triglycerides as well. No other medication will give you quite that degree of improvement. And Lipitor, of course, has been proven to be safe in adults for many years now. So simvastatin, again, excellent improvements, which is why I like it. Whoops, let me go back here. Apologize for that. Which is why I like it. And of course, it's available in generic forms. Again, significant improvements in total and LDL cholesterol, improvements as well in HDL cholesterol, and significant decreases in triglycerides. I like it as well because it is relatively inexpensive and accessible to most families. Let's consider a third case study, which will illustrate another form of lipid disturbance. So this time, Eddie is a 12-year-old boy who recently underwent lipid screening. 3 of his 4 grandparents have heart disease. Both his parents and his older sister are smokers. It's an unfortunate situation. His father has hypertension and type 2 diabetes. He has a BMI percentile of 99.3. The average of 2 fasting lipid profiles is shown below. So his total cholesterol, not too bad, 190. LDL-C, not bad. HDL is somewhat low, and triglycerides are quite high at 260 milligrams per deciliter. So it's a very obese kid. And this is a pattern of lipid disturbance that is common to children who are insulin resistant, who have the metabolic syndrome, characterized by high triglycerides and low HDL-C. Now, what do we do about it? Well, he's only 12 years old, and it's true that statin drugs are indicated as young as age 10, but he really doesn't have an elevated LDL, nor is his total cholesterol all that high, and statin drugs target LDL primarily. So let's say that the case study continues. He and his family attempt to implement the Child 1 and Child 2 dietary changes and physical activity with little sustained success. In other words, it's not that they've implemented them and that he hasn't shown any improvements in lipid profiles, they haven't been able to implement them, which of course is a situation we're all very, very familiar with. His lipid profile, not surprisingly, is unchanged. So what would be most appropriate? So this is a tough question to answer, and there's no absolutely correct answer. But we certainly should be continuing to encourage lifestyle changes. He could benefit from achieving a healthier weight. So the general recommendations that we've discussed already, as well as trying to promote achieving a healthier BMI percentile, should improve his lipid profile significantly. There really isn't any better treatment to elevated triglycerides, for example, than weight loss. And we know that elevated triglycerides over the long term are a significant risk factor for cardiovascular disease. A question comes up quite often, what about fish oil, EPA, DHA? Well, this is a really tough question to answer. So in my term as the clinical director of the Pediatric Weight Management and Wellness Center at Children's Hospital Pittsburgh, treated a large number of kids with fish oils and noticed very, very significant improvements in triglycerides. Not much change in the other lipid parameters, but essentially what we were looking at were many children like Eddie who had a pattern characterized by elevated triglycerides and low HDL cholesterol and elevated weight. So typical insulin-resistant kids. As far as the low HDL goes, encouraging physical activity was our primary strategy. As far as triglycerides go, EPA, DHA was a good part of the strategy as well, in addition to lifestyle changes. The problem is this recent meta-analysis, which is actually methodologically quite rigorous, that has come out just in the last 6 months or so, which talks about the long-term impact of treatment with omega-3 fatty acids, fish oils, in adults, and have found that it really does not improve cardiovascular disease or all-cause mortality. The components of cardiovascular disease being cardiac death, sudden death, myocardial infarction, or stroke. So these are adults who have been treated for many, many groups overall. So somewhat of a disappointing result, and makes you question what is the point in treating children with high triglycerides with EPA DHA. Well, no right, absolutely correct answer. If the triglycerides are very, very elevated, 500 or higher, the child is at high risk of pancreatitis, in which case, significant dietary changes as well as fish oil would be beneficial in those circumstances. And maybe even a statin if they're at such a high risk. So that might be part of the rationale for treatment with these compounds. As I mentioned earlier, the best approach would be weight management. The other challenge we have with the fish oils is their prescription preparation, which is now called Levasa, is not covered by many insurance plans. It's very expensive, definitely out of the range of most families. So what is proposed, of course, is that a lot of these children obtain fish oil preparations that are over-the-counter, and some of these are excellent. So the ones you can buy at Costco, for example, some of the ones at GNC are excellent. Unfortunately, because the over-the-counter preparations are not as carefully regulated as prescription medications are, it's difficult to say how much fish oil is actually in these compounds and what else might be there, et cetera. So that's always a difficult situation. It reminds me of niacin, which of course we know is effective in raising HDL cholesterol, but of course has some other unfortunate side effects. And when niacin was prescribed for lipid disturbance, the prescription preparation was called Niaspan, which of course had an FDA-regulated quantity of niacin in it. But many companies were marketing something called a no-flush niacin. So flushing is very common with niacin, and it's a really undesirable side effect. And so a lot of patients went out and bought this no-flush niacin and felt, wow, this is great. I'm not experiencing any of the side effects I had on the prescription medication. Well, it turns out there was a reason that it was no-flush niacin. There wasn't any niacin in it. So that gives you an idea of the hazards of sometimes relying upon over-the-counter preparations. So to summarize, the screening recommendations now include universal screening. And this is between the ages of 9 and 11. You do not have to do an initial fasting sample. You can do the total cholesterol minus the non-HDL-C, the non-HDL-C by subtracting the HDL. And then, depending on those values, you can obtain a fasting lipid profile thereafter. So it saves you a lot of fasting lipid profiles overall in your practice. Aggressive promotion of lifestyle changes is the initial treatment for the majority of children. And I can see, given the quality calls we've had and my experience of everyone involved in this MOC, gosh, it is tough to promote lifestyle changes, and it's even tougher to encourage families to adopt them. So what are we doing? Is there really any value to screening from that standpoint? And I think there is. And I've seen it happen many times myself, that you have a child who's overweight or obese, and the family is not terribly serious about lifestyle changes. When you show that parent a lipid profile that indicates that there is a problem, it does sometimes provide a powerful motivation to adopt changes that they would not have done otherwise. You're telling Eddie that his parents that, look, his triglycerides are out of control, his good cholesterol is low, and it does have somewhat of an impact. Of course, all parents are concerned about the health of their children, and here is concrete evidence in numbers to suggest that that health is deteriorating. The statin drugs should be used when indicated according to the NHLBI guidelines. That having been said, most primary care pediatricians and family doctors are uncomfortable initiating statin therapy on children, and this is something that can be done in conjunction with a specialist, or at least with the advice of a specialist. However, I think that if you have a child whose lipid disturbance is quite significant, let's say, or if it's an adolescent between the ages of 17 and 21, when a universal screening is recommended at least once, and so the child is close to adulthood and has a significant lipid disturbance, in addition to lifestyle changes, it is completely appropriate to begin statin therapy. Okay, thank you very much, and I'll take any questions. Back to you, Sarah.
Great. Thank you very much, Dr. Rao, for that presentation. I'm going to go ahead and see if anybody has any questions at this time. If you do, you can go ahead and raise your electronic hand, and if you can't do that, there is a button at the bottom where it says questions, where you actually have the ability to type your question into a question box, and we'll be able to read it to the group. So does anybody have any questions at this time? All right, so it seems that we don't have any questions at this time. Obviously, if in a little while you think of a question and it's just burning a hole in your brain, please reach out to us, and we can certainly get those questions to Dr. Rao, and hopefully we can answer those for you. Another quick note, the study that Dr. Rao mentioned in his presentation, the meta-analysis about the omega-3s, we do have a copy of that study, and we will be posting it on our website along with the presentation. So if you wanted to look at that a little bit more in depth, you shall be able to do so. Again, so if there aren't any last minute questions, I'm going to go ahead and say thank you again for everybody attending, and I hope everybody has a great holiday weekend.
Thank you, Sarah.
All right, take care.